Probably if the head is avascular and the joint cartilage is eroded, we have no option but to go for joint replacement surgery. If we review the literature, convergent arthroplasty or a salvage arthroplasty is defined as a surgery following an open or a arthroscopic hip surgery with or without a retained hardware that is removed and replaced with the arthroplasty components. Failure following fixation of neck of femur is common, and 1 in 10 patients will eventually land up with salvage arthroplasty. Salvage arthroplasty is a complex procedure, mainly because the bone is weak and osteoporotic, hardware is retained, and anatomical deformity may exist in the proximal femur. What are the indications? Post-traumatic arthritis, non-union, malunion, or a failed hardware. All these are the indications for salvage hip arthroplasty. Last month we had a paper in Journal of Arthroplasty which has divided salvage arthroplasty into 2 groups, early and late salvage arthroplasty. Early salvage arthroplasty is when it is done within a year of index fixation of the neck of femur, whereas late is the one which is done after 1 year. So the candidates for early are the ones who go into non-union or have a screw cutout or an implant failure, whereas late salvage arthroplasty, the candidates are post-traumatic hip arthritis or avian. However, if we look at the complication rate is much higher in the early group compared to the late group. Why so? The increased rate of complication is because of the second hit phenomena. Within a year, patient is undergoing a primary index fixation of the neck of the femur fracture, and at the same time, once it fails, it's converted into a THR. Vis-a-vis, for those who undergo late convergence, there is something known as stabilized biological environment. Probably the body goes from a catabolic phase to anabolic phase, and hence the complication rate goes down. This doesn't mean that we should push all of them into a late salvage, because the more we push them, they will be in a prolonged period of pain and functional impairment. So as and when the patient presents, you will have to give him a solution. So even the recent literature has shown that majority of the patients who undergo salvage arthroplasty are for avian or for post-traumatic hip arthritis. So what is the workup that you would do in this patient? First is you will get the X-rays. You should always try to see the entire femur. If required, you can do a 3D imaging. Second important point, always rule out infection. Do all the infection parameters. If the markers are increased, go ahead and aspirate the hip joint. Send it for culture. If still in doubt, you can even do a Mars protocol MRI. Always evaluate the previous surgical scar. You should know the hardware, what is in situ. You should know that hardware in and out, and if possible, assess the bone quality. The templating, it has its own advantages. So salvage arthroplasty you can do either in 1 stage or 2 stage. All aseptic cases, you can do a 1 stage where you remove the hardware and do a THR in the same sitting. Whereas for septic conditions, you will have to go for a 2 stage. In the first stage, remove the hardware. If required, put in an antibiotic cement spacer, give them antibiotics for a period of 4 to 6 weeks, and once the parameters normalizes, you can go for a second stage THR. If in doubt, probably a 2-stage revision is a safe option. Now, what are the red flags to pick up this latent infection? If there is no pain-free interval between the index surgery and the time you will be going ahead with salvage arthroplasty, think about a latent infection strongly. Second is, if the patient is giving you a complaints of night pain or a rest pain, that is the second red flag, and obviously a draining sinus would be pathognomonic of this. This was a case of failed fixation, and this was done in a single stage, and it was aseptic. Vis-a-vis, this patient had a discharging sinus, so in the first stage we went, removed the implant, did a thorough debridement, 6 weeks of antibiotics, parameters normal, and then in the second stage a THR was done. Some technical tips about hardware removal. You should know if possible, the company of the hardware. At times you may have to do a selective hardware removal. If the head, you are unable to take out the implant from the femoral head, you may have to break the femoral head. It's always nice to have a high-speed burr and diamond tips with you. Even if the screws are broken, then this trephines helps you to remove that broken screw. And if you are dealing with a PFN nail, probably a universal nail removal set may be helpful. Some tips about removing the cannulated screw. If one of the CC screw is going below the level of the LT, it is wise to put in a cerclage wire over there, as that's where the crack may propagate. So put first a cerclage wire and then remove this implant. You should have various types of screwdrivers with you, a star-shaped, a Phillips, a hexagonal screwdriver, and even to remove a 6.5 cc screw, if it's a synthesis screw, you need a 4 mm screwdriver, whereas if it's a striker screw, you need a 5 mm screwdriver. So it's quite an implant company specific, so you should be prepared. The second thing is about removing a DHS. A golden tip here is first dislocate the hip joint and then remove the implant, not the vice versa. That decreases the chances of a periprosthetic fracture. There are some areas where the bone will grow, the area around the lag screw, the reacher screw, or even on the medial side of the neck. It is important to burr out that bone, or else you may put in your stem in the wrong direction. Some technical tips to remove the PFN, you should try to localize that if required, even with a C-arm. What happens is, the more you release the gluteus medius, the more you are weakening the abductor lever arm. So that increases the propensity of hip dislocation. How to deal with the acetabulum side? The bone stock will be weak because of late presentation. So avoid forceful impact. If possible, augment it with a screw and choose a cup of your choice. A word about the stem selection. We have two options, either go for a cemented or an uncemented stem. So follow the Droz classification. For a type C, you will obviously go for a cemented one. A metaphyseal fitting stem would be preferred in if there are CC screws or a two-hole DHS has been used or a FNS system has been used. Whereas you may have to go for a diphyseal fixation, probably if you are doing a revision for a PFN or for a four-hole DHS. Another important point, the length of the stem. The length of the stem should exceed twice the cortical width beyond the last stress riser. So you can see the stress riser created by the distal screw. So when you revise it, you should go significantly beyond it, about 5 to 6 centimeters. The intraoperative challenges that we face are, it's a stiff joint, the bone is weak, so handle the bone with care, do a judicious release of the capsule, the operating time will be long, the blood loss will be long, so a minute more. So the literature has shown that the common complication is infection and dislocation in this group. The earlier series showed that the dislocation rate is as high as 20%. Also, if we look at the survival rate and compare it with the primary THR, for salvage THR, it is much less. However, recent series has shown that the dislocation rate has gone down, mainly because of the use of large heads as well as the use of the dual mobility liner. So dual mobility liner do have a role in this thing. At times you can bone graft this space, whatever has been created. Is this arthroplasty rewarding? Yes, the hip score definitely improve. So the advantages are pain relief and improved quality of life. So what is the take-home message? Salvage hip arthroplasty is a safe and effective rescue surgery. In the event the internal fixation fails, the results are more often compared with revision arthroplasty than a primary arthroplasty, and it is important to perform this salvage arthroplasty correctly and to the higher standard, which may benefit the patient in avoiding high-risk revision surgery in the future. So that was in short about the salvage arthroplasty. Thank you.
Thank you.